though I mentioned the intuitive Da Vinci robotics system, it's because they are the de facto leader in robotics. And so that is not an endorsement by any stretch of the imagination. It's just because they are the de facto leader in the field. So I'll just talk a little bit about evolution of minimal access surgery, and then kind of mention some companies in the robotic field so that we know that I'm not advertising for Intuitive. A little bit about the benefits, the drawbacks, and then kind of try to answer the question, are we ready? So currently there are several companies that are actually FDA approved in the robotics field. Okay, as I said, Intuitive Surgical is the leader because they have had the sphere, for almost 20 years now. There are others that have come into the market, but actually there are about 40 companies that are in the robotics field, some of which are at various stages of research and development. And very soon we are going to see an explosion of these companies. But a lot of them are kind of limited in different areas. And so they are not necessarily going to challenge Intuitive. So in terms of how laparoscopy has evolved, I mean, laparoscopy has been done since antiquity. Actually, the first cystoscope was developed in 1887. And at the time, they used a modification of Edison's new light bulb that he had created to provide light source for that. There have been various iterations of laparoscopy, which have been called peritoneoscopy or organoscopy or cilioscopy throughout the years. But actually, I think the father of modern laparoscopy is Kurt Sam, who was a gynecologist in Germany. And actually, when he was talking about his new procedure, in the middle of his procedure, they pulled the plug from the wall, and they said that he needed a brain scan because it's only someone who is insane who would ever think about doing something like what he was talking about. Yet now we call him the father of modern laparoscopy. Sometimes the forerunners tend to be ostracized. Now, the first laparoscopic cholecystectomy in the United States was done in 1988, even though somebody in Germany had done one a couple of years earlier, but they didn't really publicize it that well. Once it started, it exploded, and there was a debate about cost. So again, there's a lot of talk about cost here, but then eventually it was found out that the benefits outweighed the cost because in the United States, especially, kind of length of stay is a big issue because hospital stay is very expensive. A single day of hospital stay is more expensive than the most expensive hotel. So, cutting down length of stay actually saves in terms of cost. In 1992, there was a panel that was organized, and they said that laparoscopic cholecystectomy is the preferred approach for gallbladder surgery. And this was just 4 years into the explosion of laparoscopic surgery. Now, in terms of laparoscopy, as has been said, any surgery that can be done open in the abdomen and in the thorax can be done laparoscopically, right? There's a steep learning curve, and that has been talked about a lot, and therefore, you don't just wake up, as has been talked about, see one, do one, teach one. No, there's a lot, there's a steep learning curve, and even when you are so-called experienced, you still need to keep up your skills, and simulation helps with that, but there's a lot that needs to be learned. But overall, laparoscopy is safe, and when it comes to management of malignancy with laparoscopy, initially there were questions about whether it should be used because there were a number of publications that talked about port side recurrences, and so there was a big randomized study, the COST trial, that showed that it was safe in cancer. There are still questions about its use in rectal cancer, which is beyond this talk. Now, when it comes to laparoscopy and its applications, a lot has been talked about, but it cuts across a lot of disciplines. And interestingly, when we talk about laparoscopy, we divide it into kind of simple laparoscopic procedures and complex laparoscopic procedures. So cholecystectomy and appendectomy are considered simple laparoscopy, okay? The rest then go into the complex laparoscopic procedure. So in surgical training in the United States, you have so many numbers that you have to have for simple laparoscopic procedures, and so many numbers that are required for complex laparoscopic procedures. The benefits have been talked about, short-term and long-term, so I'm not going to belabor those. In terms of new horizons in minimal access surgery, we have single port laparoscopy, where you work through just a single port instead of having multi-ports. Then, the other new things are trocharless laparoscopy, where we use magnets to put instruments in and use magnets to manipulate the instruments rather than putting trocars in. So that is kind of coming up. The natural orifice transendoscopic surgery, which we do in various forms, but again, that is also an area that is coming up. And then transanal total mesorectal excision, this is for the colorectal surgeons, is another way of approaching rectal cancers from below by using laparoscopic and robotic equipment. Obviously robotics, that is what I'm supposed to talk about. And then there is also what is called the digital surgery platform, which incorporates, using robotics, using advanced visualization, advanced instrumentation, data analytics, and connectivity into practice, where you are not just using an instrument, but you're using your data that helps you improve. So we learned about mentoring, coaching, for example. This is where you get real-time data based on your own data and your own practice to help you improve using data analytics. And this is a platform that is coming up, and hopefully it will be in practice soon. Now, when we talk about robotics, it's actually a misnomer, because when you talk about robots are supposed to have independence and automatization. So robots can kind of be independent and think on their own. Really, when we talk about robotics, it's just a tool that the surgeon controls to do surgery. And so kind of robotics is it's a misnomer. Now, again, as I said, the Da Vinci robot is the de facto leader because they have been in the market for a long time. And there is a surgeon console, and then there's a bedside console which has the arms for the instruments, and then you have a monitor, for example. So applications of robotic surgery, same areas as in laparoscopic surgery, from cardiac all the way down to urologic surgery. So essentially, it can be applied in any area to help the surgeon. Advantages are that you have 3D vision when you sit at the console. Robotic instruments have endo-wristed action, so you have 7 degrees of freedom. You can move like the human hand. In laparoscopy, you only have 2 degrees of movement, and so that overcomes that limitation. It's a stable platform. Somebody talked about, the assistant giving you seasickness. Here, it's a stable platform. You control the camera, you control everything at the console, and there are other applications that you can use. Now, it has been said that robotics actually can overcome the learning curve for laparoscopy, because you have people who never do laparoscopy. They are able to get on the robot and actually be able to do minimally invasive surgery. That has been proven in multiple studies, especially in urology with robotic prostatectomies. And people who've never done any laparoscopy before, you know, have a shorter learning curve to doing minimally invasive prostatectomies. And so that is kind of one of the advantages of it. And obviously the surgeon is sitting down, and so the ergonomic stress of kind of twisting yourself to get in awkward angles, you know, doesn't happen. The big disadvantage is cost. We've talked about cost a lot for even laparoscopy. So the robot, you know, the upfront cost of acquiring the machine is about $2 million. And then there is cost of disposables. So per case, you know, it's about $2,000 to $3,000 per case. Now, the most outrageous thing is that the robotic instruments can be used only 10 times. So if you take a robotic grasper, you can only use it 10 times, and it's programmed. So on the 11th time you put it in, it will not work. It will say, you cannot use it. So guess what? I mean, after every 10 uses, you have to get a new one. And that is how that company makes a ton of money. And so that makes it very, very, very expensive to use. And then also there's a service contract, which costs about $175,000 a year. You have to have that because it says for safety. Because they run almost 1 million checks per second on the machine as you use it. They have to be able to kind of, if there's a problem, they have to be able to fix it right away. You know, there's need for training. It takes longer to do the surgery. So the question is, are we ready? I mean, I'm sure the last slide kind of summarizes it. The cost is prohibitive. I mean, we have needs for other, you know, things in our environment, and especially, you know, we're trying to develop laparoscopy and we are not even there. And so the issue is, I think we are not ready. And the other things is, even if we had it, you know, the ability of patients to pay, we've seen how much it costs. So can they actually afford it? Do we have stable electricity? Somebody mentioned that. You know, you don't want to be doing surgery with a robot and then in the middle, electricity is cut off. I mean, that would be very difficult. And then also, you need internet bandwidth for real-time troubleshooting and real-time mentoring, which can be done with the robot. Anyway, this is my last slide. The dilemma we have is that we need to balance the need for cost-effective use of resources against being left behind. So the question is there no hope? You know, I mean, we've talked about cost and the fact that we are not ready. Does it mean that we should just fold our arms? I don't think so. I think we need to balance those competing things. But from our own environment, I think we need to start thinking about being ingenuitive and developing technologies that work in our environment. Because the Western industry, they are motivated by profit. And coming to this sub-region is not profitable for them. So they are not going to be, you know, kind of wasting their resources on them. And I think that as we go forward, and even though we are struggling with resources, we need to think about ways that we can create technologies for ourselves that are cost effective, so that we'll be able to kind of not get left behind. But I think the last thing is that we probably need to go through the growing pains, okay? We are at the beginning of laparoscopy kind of getting a foothold in the sub-region. So we may have to get through that. You know, I guess Senegal is fortunate enough to have, you know, multiple sites that have laparoscopy. But I think for the rest of the sub-region, that is not the case yet. And so I think we need to keep grinding and getting good at laparoscopy. And I think over time, we are going to be able to get to the point where we can then transition to the more current technologies when our economies are better developed. Thank you.